What we're going to do next is invite up Atul and a panel to revisit, reflect on the reports that got us here in the room today from 10 years ago. We want to do that again through that asset-based, appreciative inquiry mindset. So we want to think about what those reports give us today. And then we're going to move into talking about, what do we do about it? What's the path forward? How do we build a movement in order to help make progress in this arena? So with that, I'm going to introduce Atul Grover, and I have his title, but he told me I don't have to say it, so I'm not going to try to find it. So I have Atul Grover. He's going to moderate the upcoming panel, and he's going to invite his panelists with him. So welcome, Atul.
All right, thanks, James. And so do we have our virtual panelist joining as well, Fisher? Stephen Tush? Toish? Excellent. Toish.
Atul, unfortunately my video isn't working, but I can hear you.
Nothing to see here, Steve. That's fine. And just, Alina, can I break the news of our special guest? All right. So, sorry, I was just texting with Jerome Adams, the former Surgeon General. He should be able to join us right at 3:05, James, and dial in. So please, I'm going to echo James and get back from the break on time. So you actually are in the room for that. So I'm delighted to be here, and thank you to the staff, Alina in particular, for helping set this up. And I am a big fan of everybody on this panel and their work. So Steve Wolf is, as he said, at VCU. He is a director emeritus and senior advisor for the Center on Society and Health. Martha Gold is professor emeritus at the Department of Community Health and Social Medicine at CUNY. And Steve Toish is a senior fellow at the Schaefer Center at UCLA. So I am really here mostly just to moderate, but I can't help but give you a few of my own thoughts as we start. And I really enjoyed the conversation this morning. And I think that some of the questions that James and others have been asking and try to answer are really important. You can't solve a problem until you name the problem and figure out exactly what it is you're trying to do. And so, as somebody I'm a general internist, public health person by background, and looking at the work of the panelists that have authored and worked on these prior reports, I think it's pretty clear in terms of, from my reading of these things, what are we trying to do, right? And I think that's something we have to be clear about, at least internally, before we decide what language we want to put around it. We should at least all understand what it is that we're trying to do. And so I'm going to ask for the panelists to give us some reflections on what they got from the prior work that led up to this, but then also what they've heard thus far in terms of promising approaches, whether that was in our breakouts or through others that they have interacted with. But we know that income really is tied closely with life expectancy, and it sounds like what most people think about when they talk about the failures of health or health care in the U.S., they often refer to life expectancy. So let's say you want to improve life expectancy. What do we know is tied to that? Some of the things we've talked about this morning, like income, poverty reduction, education, social welfare, nutrition, housing security, those aren't generally sexy things. I would say that one of the challenges, and as close as we've come to something like the child tax credit during the pandemic, a lot of the other things that were in the Biden administration's original proposal around Build Back Better were other things that I think you're talking about here today. Pre-K through 14 or 16 education, guaranteed child care, if not close to a guaranteed basic income, at least support through the child tax credit. All of that is likely to expire, and it's unlikely to get momentum to achieve those things, at least in the next 2 years as we lead up to the next election. However, I do think it's a great opportunity for this group and others to really refine the message and to talk about, what is it that we're trying to achieve. I I am a firm believer that, income is a big driver of this, yet it's difficult in this country to have a conversation about saying, well, everybody should have a certain income. We look at our average income in this country, but we've all seen the maps, whether it's the DC Metro or whether it's a map of New Orleans proper, which shows that you've got life expectancies that range from 80 or 85 in one part of the city, like where I live in Montgomery County, down to 55, 60 or so in parts of New Orleans, in Iberville, or looking at parts of Anacostia. And a lot of that can be tied back to income. There's also access to healthcare. There's other issues. But a lot of it is tied to things that are not directly related to one of the hats I wear, that Steve wears, in terms of being a clinician. Right? It's 20% based upon the framework that was laid out. So if you have an 80% chance somewhere else of actually influencing life expectancy, it sounds like your bang for the buck, and literally the buck in this case, is going to be to work on things like poverty reduction and education, which is not to say you shouldn't still worry about access to care and insurance rates and affordability of care. I think those are all critically important. But in terms of what's going to move the dial on the measure that you are talking about, what do we have influence over? And I do feel like, personally, the health system gets everything else lumped into it because we don't really know where else to point, and we can't deal with the fact that our state, local, federal governments have failed at social policy over the years. It's become worse and worse. And so we look at a $4 trillion system and say, well, there's got to be money in there somewhere. Pay for housing, do food security. You guys fix it. But we're probably not the best people to fix a lot of stuff. I am not the most skilled at dealing with some of these issues, but I'm happy to work with people who are. So what I'd like to do is maybe start with the panelists that we have in front of us here, and I'll just go in the order that you're sitting here. So Martha, go to you, and then Steve Wolf, and then Steve Teusch virtually. But just give me a sense of, the couple of 5-minute highlights from the prior reports and what you've heard this morning that you think identify the problem and identify some of the potential solutions that we should be working towards in order to actually make some movement on that measure.
Thank you. I'm very happy to be here and having these conversations. I really am admiring how this symposium has been organized. And I left this chair for Steve Wolf to speak in, knowing you would do that, and he sat there, so now I have to go first.
He's tricky.
Yeah. I want to start by saying that I feel a real loosening of associations based on what I've heard today. I came here with some ideas about what I wanted to say, and I may be a little stream of consciousness as we chat today because a lot of things have sort of sparked in my mind. I know, my first sort of duty here is to just remind everybody about the report in 2012 that really asked that the United States over the next 10 years try to achieve parity with OECD averages in life expectancy and cost. And just to remind everybody, we haven't done that. Not only have we not done that, it's probably gotten worse in terms of the cost piece. We're still 2 years behind the life expectancy of the average OECD nation. And we're about twice as much in terms of our expenditures on the medical care portion of life. And so that's depressing. The other piece that I really want to highlight here, and I sort of come and embroider this through, is the other measure that gets collected internationally and also by Gallup here is Cantrell's ladder of well-being. And on Cantrell's ladder of well-being, we rank 17th internationally, and there are 3 different levels of Cantrell's ladder, and this is in your handout. But there's from some 0 to 3 is essentially, now I'm going to forget the actual term, but it's suffering, I guess is suffering. And from 4 to 6, it is struggling, and from 7 up, it's thriving. So we don't even make it to 7, which is really pretty depressing. And as somebody who's been sort of in the public health and medical care side of the world and have sat here in the round table and as a founding member, one of the things that I've said and I say again today is I really think we need to talk about well-being and not health. And I have asked when I was on the roundtable that we rename it Roundtable on Well-being rather than on Health. I think that the representatives on this roundtable, and this is very parochial, really need to be broader than what we've done before, and come from different kinds of sectors. When people don't galvanize around health. When you lose your health, you appreciate what you've lost. But by that time, you don't have the energy to do a whole lot of stuff. But people do care about their job security, about where they live, how safe they feel. And so we know this. I mean, and we do care about health, and health needs to be, sort of our anchor, but we don't have to talk about it that way. And so I think we really need to sort of talk more about well-being in this world. So that's my first series.
Do you think people can galvanize around well-being?
I think that, again, and this is another piece of this conversation, we have this notion of the GDP, right? Everybody in the United States thinks that they know what the GDP is. Nobody really knows what it is, but, we sort of watch it, what happens to it. So if we had something that we could rise up in that same way that had to do with well-being, that everybody knew what that was, and everybody felt, with American exceptionalism, we should be better than the next, international country. I think we should find that measure, and that's going to lead me back a little bit to the earlier report that we made among the trilogy that came out in 2010, 11, and 12, and that was on measurement. And I just want to speak for a moment about measurement. We asked in that report that we really beef up our measurement system in a sort of federal way, that we have measures that would track across state, local, and federal arenas, so that we could know how we were doing in relationship to each other. And that's has begun to happen for sure, and built under the county health rankings, under America's health rankings. I think we've done a more impoverished version at the federal level. And measurement, gives more transparency. It can galvanize public and policymakers, and it also creates accountability. And so I think one of the things I really feel that what we need to do better federally is to make people aware of where inequities, disparities sit, and make that part of dinner time conversation in the same way that if GDP comes up at the dinner table. But in the same sort of vein, that needs to be something that we shine a light on. I'm going to stop there. I have other things that come out of this morning, but I'm going to just...
Well, we'll save my bet. I'll ask you a question where you can get some of those in. So, Steve Wolf, you're next.
Well, I want to defer to Steve Teutsch because he was a partner in crime with Martha, whether he wants to say a bit more.
Sure. Steve Teutsch, are you okay going next if we go to you?
Sure. But as Steve said, Martha and I were sort of bonded at the hip, so she's dived into many of the things that I was going to reflect on. But I want to reflect on it a little bit in terms of the recent COVID epidemic. And as we all know, a crisis is a terrible thing to waste, and we seem to be in the process of wasting it across several dimensions. One is on the metric side. Our reports reflected on the fact that we needed to have a good integration even of our basic clinical information and public health systems. And we really didn't get that over the past decade, and we paid a price for that when we had to patch together an information system even during the COVID epidemic. At the same time, we got some good things out of the epidemic, and I hate to reflect on it as good things, but we did look at the kinds of investments that were now being made in families in terms of payments to folks who needed them and other kinds of things. Sadly, the momentum for those seems to be waning, and we're seeing them getting phased out. But it shows what can be done, and when those needs are recognized and acted on in a prompt way. Also, in terms of the metrics, we did want the the federal government and the states to look in much more into the social determinants of health and the environmental determinants of health, and monitor those very much in the way that Martha described in terms of well-being. We have a pet peeve that I'll mention here too, that the medical care system has co-opted the term health, which has complicated our job, and that in some ways is why we have to turn to words like well-being that reflect that broader set of human needs that allow us to thrive and prosper. But the county health rankings, America's health rankings, have really taken the bull by the horn and tried to come up with a set of metrics that reflect that broader range of social and environmental determinants, and are delving into some, the challenging areas such as how do you measure equity? How do you bring that home to people in meaningful and impactful ways that can change the dialogue? Turning back to the clinical care system, where they've started making some strides, is at least when I go to my doctor, they ask me about all kinds of social metrics, and how I'm doing on poverty and violence and all kinds of things. But I don't see they haven't really figured out what to do with that information. It's on all the intake forms, but that seems to be pretty much the end of things. And if they're really going to take part in this and be active, they need to develop those mechanisms along with all their partners that are out there who are better equipped to address many of those human needs. The other thing that our reports talked about was building a stronger public health system where everyone had a minimum set of public health services that would be available to them, and that hasn't really happened either. As we've expanded the needs that public health needs to do, it still, unfortunately, is mired in some of the traditional things that it has been doing for years and does quite well, because when things don't happen, that means the public health system is functioning. But it's made it very difficult to embrace many of the kinds of things we've talked about here and across other sectors, across other parts of the community, to really come up with a broad-based coalition that can move things forward. There are isolated examples of where that's happened. We've heard some of those today, but that needs to be part of the way we move forward, and that takes investments. Our reports talked about where that money would come from or should come from. It hasn't, but the needs are still there and can move forward. So let me stop there. I know Steve has some very important things to say.
Fabulous. Next, Steve.
So Steve, number two. So I'm speaking, representing the committee that produced the report, Shorter Lives, Poor Health, which was issued in 2013. I want to take a minute to sort of take stock of where we are, what that committee found 10 years ago, and what's happened since then. But I'll just telegraph the fact that after I get through talking about the health situation, I'm going to recommend that we stop talking about health in terms of our outreach along the lines of what we talked about this morning. I've really been convinced by that. Our report was charged with comparing the health of Americans with people in 16 other high-income countries. Our title basically summed it up, Shorter Lives, Poor Health, across dozens and dozens of metrics. I actually have to disagree a little bit with, and I rarely do, with Martha and Steve. I think we're awash in metrics. We've got lots of data on how bad we're doing. It's not a unified measure, I agree with you, but the evidence that committee looked at 10 years ago was overwhelming and horrific, actually. Every age group, every racial and ethnic group, all geographic areas, and it's worse, obviously, for marginalized populations, which is an issue I'll come back to in a minute. But even rich Americans, we found, were dying earlier than rich people in other countries. Since that report was issued, at that point, the thing we were warning about was that life expectancy was increasing more slowly than in other high-income countries, a trend that had begun in the 1990s. What happened after that report is we plateaued altogether, and life expectancy started decreasing in the United States while continuing to climb in the other high-income countries. So the gap between the U.S. and other peer countries was widening dramatically in the run-up to COVID-19. that plateau and dropping of life expectancy was caused by an increase in midlife mortality, meaning young and middle-aged adults from 25 to 64. Death rates in that population have been climbing since 2010, and that did not happen in any other country, just us. So this was the thing that we were warning about before we even knew COVID-19 was coming. And then the pandemic obviously accentuated this problem, not only in terms of the factors responsible for the dismal performance of the United States relative to other countries, but what happened to our life expectancy. Other countries took a hit too. Their life expectancy decreased during the pandemic, but no high-income country on the scale of the United States. And in 2021, after the vaccine became available and other countries began to recover from the pandemic, U.S. life expectancy continued to plummet. So all of this, and I have to apologize to Tiffany because she said at the beginning, "Let's keep this positive." So I'm not following instructions, but and I do want to turn to a positive theme, but I think it is necessary to confront the reality of what we're dealing with, and it's really the engine for our desire for transformative change. All of us in this room. So we can sort of stipulate that we all care about population health and health inequities. So clearly that's what our motivation is. In terms of convincing society more broadly, politicians, the ideological divide, I think we need to transcend the issue of health. I do want to come back to the report, the 2013 report, in one respect, because I do think, at least for me, the conceptual framework that committee used to try to investigate why it was that Americans were so sick compared to people in other countries, that framework provides a bit of a map for policy solutions in my mind. So the committee identified 5 domains that it considered potentially responsible for why Americans are sicker than people in other countries. The first one that comes right to mind is the healthcare system and the public health system, particularly the healthcare system where other countries have universal access to care and fewer barriers to care. And that's an easy one that people immediately gravitate to. Another is personal behaviors. So we found data to show that Americans behave differently than people in other countries, whether you're talking about caloric intake or gun ownership or opioid use, a variety of other factors. We have to really be careful about the narrative of personal responsibility. So we've learned in population health that personal behaviors are driven by social and economic factors in our environment. So the committee looked at those other 2 domains. So domain number 3 was social and economic factors. And Atul's point about where we're doing with income and is clearly very important because much of the population has not seen economic growth. Americans have higher wealth inequality than in many other countries. But getting away from income in other aspects of social and economic well-being, we're being outperformed by other countries. Education, our major pathway for income, other countries are outperforming us on education. Housing, many other basic social economic factors that shape our health are inadequate in the United States. The fourth domain is the environment, and we thought about this in terms of the physical environment and the social environment. So the physical environment, the way our cities are designed, our built environment is not as conducive to physical activity and so forth. You know, you go to Amsterdam or whatever, you can get run over by all the bikes because everybody's cycling to work and shopping. Our cities are not designed that way. But importantly, also the social environment in our country. We have, and we've talked about it already, we have this 400-year history of systemic racism in this country, and the legacy of it is responsible for a tremendous scar in our social environment and social inequality, and now in more recent years, more social and ideological division in our country that's contributed to it. And then the fifth domain, I'm going to wrap up soon, is public policy. So our committee felt that was sort of a macro structural factor that probably was the most important of all because it had implications for the other 4. So obviously we've had a lot of discussion today about, policy solutions that we need to target, but I think that framework may help us organize a little bit about where the different buckets are that we need to be targeting in that policy domain. If I have one criticism about our report, is that we did not say enough about systemic racism and the deep divide in outcomes that occurred by race. The COVID-19 pandemic had horrific consequences on people of color. Life expectancy dropped in the white population by about 1.2 years in 2020. In the Hispanic and black population, it decreased by 3 to 4 years. Now, people who work in the life expectancy world, those are horrific numbers. They represent huge death rates that occurred in that population. Media coverage at the time said that the pandemic had laid bare the problems in this country with systemic racism. And like others who have said today, I worry that the window of opportunity is closing. People are moving on. And the opportunity to really confront that issue is waning. So I think, to close my comments, I think we all know the kinds of policies that we could pursue to be effective. We've discussed many of them today. The tour earlier today was really helpful in seeing some concrete ideas that have made a difference. We know that other countries have figured this out. There are 15 countries that have had higher life expectancy than the United States for 50 years. I'll repeat that. 15 countries have outperformed the United States for 50 years. They have figured this out. So we know policies that can work, both that we can learn from other countries and that we can develop innovatively domestically. But promoting them and getting the political and public will behind them, I think, is really where our focus needs to be. And I just underscore the takeaway that I got from this morning's conversation, that we really need to be thinking about reframing our narrative and who delivers it.
Well, and I think a lot of this needs to be locally modified, it sounds like, and a lot of the examples that we've been given today are specific to communities. You know, somewhere in there, I think there's probably some commonalities in terms of principles around language and how to approach this. But, you know, I think to the comments raised by you and Jason and Jennifer before, the United States is an interesting country where, yes, we tend to talk about personal responsibility and eschew what a lot of social democracies in Western Europe have embraced for millennia, and in about half the country, geographically at least, you can't talk about some of the things that we're talking about here and have people be receptive. And so, I'm interested in kind of hearing a little bit about, how that local message needs to be shaped. And actually, I know once we go to the audience, Dave Chokshi wrote a piece that I recommended to folks in the last maybe 1 or 2 weeks, about some things we need to do in the healthcare system. And one of the things that he talked about was during COVID hospitalizations in New York, people were given $1,000 if they were hospitalized. Did that work? Can it work in a place like New York City, New York State? Maybe it works in other places, but how you phrase it may be different. And I think the lady of Reinhardt used to say, I would love to have the Swedish healthcare system, but you'd have to transport the Swedish political system and cultural system, right? It's not going to happen without the other pieces of it. And if you think about Anita's colleague at RAND with Uwe and Jerry Anderson said, look, it's the price is stupid. We don't actually consume anymore. In fact, we're on the low end of consumption of services, but it's the prices. I would add to that, it's the wages, dum-dum, right? Because our wages, my income as a physician is 2 to 3 times as high as what it is in other countries. Labor makes up 70% of the costs of health systems right now. It's edged up from about 60% before the pandemic. Supply chain costs are about 20%. There is no realistic world in which you lower the cost of healthcare in the next 5 years. None. Right? And politically, it won't happen. So the question is, how do we make the case for investing in some of these other things? Particularly, there are, 10%, 9% people uninsured right now. It'll go up after the PHE ends. That's 27 million people. That's roughly the entire population of Australia. We are a very large, diverse, fiercely independent, and opinionated country. How do we make the message consistent and yet malleable, adaptable as we travel around? And how would you make this argument to Joe Manchin versus, senators in Nebraska or Idaho or Wyoming or Eastern Washington, for that matter?
So this is Washington, and so I can answer whatever I want to answer, right?
You can, yes. You are entitled to your own facts and opinions here, evidently.
Exactly. I've heard some really powerful arguments for building trust and breaking bread together, and I believe in all of those things with all my heart. But I also remember a very important meeting we had at the Round Table, which was about building a movement. And one of the messages of building a movement was to have enemies, in a way, to have things you're struggling against, whether there are people or institutions. And so one of the things that I think about measurement is that if you let people really understand what the measures are telling you, if you do that by storytelling, if you do that by numbers for people who like to know numbers, you can get people energized, you can get people exasperated, you can get people to move. And so I'm, again, I want to go back to this notion of figuring out a way to, in a more grassroots way, to get people energized to make change. And some of that obviously is making things apparent, making inequities apparent, making racism apparent, getting people to vote. All of those things are extraordinarily important in moving forward. The other thing I want to talk about really is the arts. A lot of things have, even though we're still in terrible shape, a lot of things are better than they used to be when I was a young person, when there were issues about, women's ability to sort of achieve, when there were gender issues, there was homosexuality, there were many more difficult problems for people of color. I understand they exist still, but things have gotten better in some ways. And the question is, how did they get better? And a lot of that, to me, are the sort of subliminal messages that come, or not so subliminal, through the arts, through film, through television. And so here's my sort of weird suggestion. I think it would be useful to get together sort of people who have been very successful in creating art in television and in movies and in theater and to places that people can access in music, and bring people together to get them interested in this and interested in sort of layering more deeply into the things they create, so that more people can sort of see themselves and see the problems more clearly. Now, you have to understand I have a second career as a playwright, so there's a certain amount of self-interest here.
Well, and I think part of the change has also been that you've got the Hollywood elite, as labeled, right? They're still making movies and they're getting put in theaters, and you've got everybody else on the internet listening to Ben Shapiro or Steve Bannon, and never these two worlds shall meet. So I think that is a challenge, even when it comes to, yes, we'd all love to have Sarah McLachlan singing about poor people, not animals, and do something about it. But I think it's getting harder. And maybe Steve, you brought up this issue of data before, and one of the things I wanted to ask was, if we look at the experience of the last couple of years, where in fact we have looked to data more, did we have a failure of technology, a failure of will, a failure of regulation? I mean, why did we have such lousy data and continue to have such lousy data? I know what the tech people's answer to that is, but I'm curious about your answer, since you brought up all these measures.
Yeah, I don't think it's a technological question. The technologies are there. I think there is a possessiveness about data, sometimes complicated by people's perception of HIPAA and privacy laws, and willingness to share proprietary rights. And people are wedded to their own systems. So I think it's a confluence of things. I can tell you, when I was at CDC many, many years ago, we wrote about this and how we could integrate the surveillance systems and have common frameworks. But all we could agree on is how to code male and female as 0 and 1, or rather M and F, because people were very bound to these things. And unless there's the leadership to really move those agendas forward, I think we're not going to see much progress. On the other hand, at a fairly, as you sort of reflected it, Tool, at a local and regional level, where there is the kind of cooperation and trust among public health, clinical care systems, and a willingness to share, those kind of things actually can and do happen. So it's not impossible, but it does take a lot of will.
And Steve, too, one of the things in the report you were referencing before, in thinking about what brings that life expectancy down in this country compared to other nations, I mean, you've got about 100,000 people a year in this country who die of drug overdoses. Less talked about, you've got 100,000 people a year, maybe 96,000, that die of alcohol-related disease. You've got about 50,000 victims of suicide, 25,000 victims of homicide. Gun violence, gun homicides are about 4 times the rate of any next country. You can trace where all that decrease in life expectancy is coming from, as your report did very nicely. So how do we prioritize? Do we talk about the individual problems? Do we talk about the gun problem, about the overdose, the fentanyl problem? Do we talk about all the conditions that lead to that societal despair, one of which is poverty, another is education, just not being secure? What do we talk about at Martha's dinner table?
I mean, I think we have a tendency in the medical and public health world to think only downstream. So the reflex is to talk about the specific issue of the opioid crisis or the obesity epidemic or other leading causes of death. But I think it's a missed opportunity to not look upstream because at the root of all of those, there's a reason why the U.S. is having trouble with all of those problems in ways that other countries are not. I was thinking about the fact that we have we have an advantage in our field. So let's say for a moment this room was filled with people wanting to increase funding for interplanetary travel, which there probably is a meeting like that could happen in this building. We'd be trying to think about how do we convince the public and Congress to put money into spacecraft and technology and spend less on our problems here on this planet to investigate solar systems. We're not in that situation. The interventions that we want to promote are the ones that are actually most important to so much of the population that's being left behind. I think that what the data show us is that we have vast amounts of income inequality in this country, and there is a subset of the population that's doing quite well. But for the rest of the U.S. population, median household income is stagnant. People feel a sense of being stuck or falling behind, and they don't see a future for their children. That's a message that, or that's a problem that exists in inner city America, in rural America, in all geographic regions. And we've talked about this is getting real. We have to relate to those problems, but the solutions to those, whether we're talking about wealth building activities or ways of dealing with the income divide or increasing opportunities for education and so forth, the solutions for those will improve population health, but branding it around data and population health language like we do, I don't think is going to resonate. I had the good fortune of being in one of Tiffany's workshops in Chicago, and what she impressed on us was advertisers don't sell their products by showing you a bunch of data. As I recall, there was an exercise, Tiffany, where you had us think about the emotions that are generated when we see advertising. So the example that came to my mind was Subaru. Subaru's tagline is love. That's what makes a Subaru. Right? We've all heard this. It has nothing to do with the performance of the cars, their safety ratings, what their gas mileage is. Those people are pros at thinking about how to package a message in a way that speaks to people, and they are obviously good at it. We need that kind of expertise of communication scientists like Tiffany, maybe bringing in the advertising community. A lot of us are not from that field, to get their help in thinking about how do we package this message in a way that's going to hit home across different sectors.
James, I'm going to turn it back over to you with the caveat that you not only do the Phil Donahue jog, but that you do the mic extend and kneel at the same time.
I will put a mic extend and kneel at some point today. That will happen. I can assure you of that. So with that, can we give a round of applause to our panel? Those who are disembodied in another place, as well as those who are here, thank you so much.